I'm going to talk about Dupuytren's disease. It's a very, very common affliction, and this is a sort of an overview of the condition, and also a talk which gives some ideas of where we're going in terms of treatment and current ideas on treatment and developments on treatment in the past few years. And it's injection treatment for Dupuytren's disease, why it's no longer necessary to be tight-fisted in a recession. Now, it shouldn't be called Dupuytren's disease. In life, you should never miss an opportunity to do the French down. Really important. And in actual fact, although it's called Dupuytren's disease, this chap was a late comer to the condition, because it was first described by a Belgian about the 16th century, but the people who actually brought it to the fore were two Englishmen, one called Henry Klein in 1777 and one called Ashley Cooper, who was his pupil in 1822. And the first gentleman actually dissected a hand and described the condition, and the second gentleman only described the condition, but in his treatise also described what is in effect a percutaneous fasciotomy, cutting the bands using a sharp instrument. So a lot of people who are English say it should be called Klein-Cooper's disease. It just happens that this fellow has put his name to it, which is typical of the French, coming late and then taking all the responsibility for success. He existed in the 18th century, and it was said that he diagnosed the condition in his coachman originally. He was a professor of surgery, very great man in his time, at the Hôtel Dieu in Paris. Now, he wasn't really famous for Dupuytren's disease, even though these days it's what he's known for. He was actually famous as a rectal surgeon, and he was most famous amongst his contemporaries for treating Napoleon Bonaparte's hemorrhoids. He had a European status on this, and even though he wrote about Dupuytren's disease, his most famous best-selling book was called The Treatise of the Artificial Anus. So next time you see Baron Dupuytren's disease, don't think hands, actually think the other end. As I say, never miss an opportunity to do the French down. Anyway, what he described was a condition of fascial thickening, and characteristically, it occurs in males over the age of 40, and when you see patients, they'll tell you, oh, it came across with the Vikings. There seems to be a sort of genetic band that goes across Scandinavia that then migrates to the various places that those people migrated to. And so first of all, it crops up in Scotland and then in Ireland from the Scottish people who travel, and then down to England. And if you look around the world, the diaspora of those people, there are pockets of Dupuytren's disease in people with Northern European ancestry. So you'll find pockets in, for instance, Chicago, in New York, in certain places in Australia. And it's because you carry the gene. There's usually often a family history of it, and it has a number of associations, including trauma. Either simple trauma, and actually often after surgery. So sometimes a surgery for a wrist fracture, a while later there will be the appearance of a nodule in the palm, which is of concern to the patient, probably not of great relevance, but it is a post-traumatic event. If you drink a lot, you can get it. If you're diabetic, you tend to get it. And in my experience, the people with diabetes actually have a pretty different disease to the common man. In that it tends to be more aggressive, and it tends to be more diffuse, and it tends to have a higher recurrence rate. It's associated with epilepsy and also treatment of that, and cirrhosis of the liver. I haven't got a clue why.
Is it just an observation that the diabetics are more prone to this, or is there a causal relationship established? I
don't think there's a causal relationship.
So
I mean, they're a group in whom it occurs in the same way. Actually, they're more prone towards developing adhesive capsulitis, and the adhesive capsulitis that they get is actually also quite resistant to treatment, tends to last for longer, and tends to be resistant to the treatments that you can offer it in terms of hydrodilatation, steroid injection, or capsular release. Curiously, if you actually take the tissue from an adhesive capsulitis, the capsule, look at it under the microscope, it looks just like Dupuytren's disease. It's bizarre. But no, I don't know the causal relationship. It's a proliferative connective tissue disorder, and characteristically it's painless, other than, again, in my experience, sometimes when it starts, because people will actually say there's a soreness or burning or feeling of discomfort in the palm, but that's usually transient, just at the outset. It's usually a painless condition in which the fibroblasts in the fascia, for some reason, and you don't know what the trigger is, become myofibroblasts. They deposit collagen, which is then aligned along the lines of tension in the hand. And in this slide, you can see all the problems it produces. It produces lumps, which is nodules. It produces cords, which are bands that go into the hand. And as a consequence of that, it produces contractures of the MCP joint and characteristically the IP joints. What do you do about it? Well, there's 4 options of treatment, actually. Nothing. If it ain't broke, don't fix it. If it doesn't bother the person, the fact that they have Dupuytren's disease is no big deal. And I see lots of people where the final decision, even though they have a Dupuytren's contracture or palmar Dupuytren's disease or nodular Dupuytren's disease, is to leave it alone. Because what we're looking for is, principally, how does it affect you? And what people say is, well, not at all, I'm just worried about what it was and how it will progress. And so, well, fine, you don't actually need any intervention if you give it a good explanation for it. If it starts to cause problems, it's usually because of either nodules in the palm, which are uncomfortable when you grip, so it's like peas under the skin, or contractures of your fingers becoming progressive, so that you have difficulty in doing simple things like putting your hand on a flat surface, putting a glove on, washing your face, those sorts of things. I used to work for a surgeon in Cambridge who said, he used to give a talk on Dupuytren's disease. He said, well, it's the sort of thing where if you have Dupuytren's disease and you shake hands at a party, the women smile and the men think you're a mason. How true that is, I don't know. There's a number of treatment options depending on the severity of the condition and the location and the sort of pattern of the disease. First of all, radiotherapy. It's actually, radiotherapy for Dupuytren's disease isn't very common in this country. It's much more common on the continent, particularly in Germany and also in some parts of America. We just don't seem to have the mindset or the education or the experience to treat very many people in this way. And in actual fact, if you look up radiotherapy treatment in the UK, there's only about 4 centres which are recommended for radiotherapy treatment. But if you look at the results of treatment at certain degrees of severity for Dupuytren's disease, it's actually pretty effective. The main worry is that you do radiotherapy, you can damage the skin, burn the skin, or get as a consequence the risk of a tumour later on, many years later. But actually that risk is incredibly small. And to the degree when NICE produced guidelines in 2010 actually recommending its use in certain disease patterns. It's really for only use in early disease. Once you have a significant flexion contracture of the finger, don't bother. But if you have nodules in the palm, or cords, if you have no deformity or less than a 10-degree deformity of the MCP joint, then it can be a very effective proposition to have a series of radiotherapy treatments, non-invasive in a way, and it can cause resolution or at least prevent progression. I recently saw a very prominent musician with Dupuytren's disease who was not in the least keen to have surgery or injection treatment, and he had quite mild disease and was considering having radiotherapy. So it is recommended. There's some very clear guidelines on NICE. It's on the internet if you're interested. Surgery. Well, there's a range of options depending on the location of the Dupuytren's disease and the severity. And it ranges from actually pretty simple stuff. You know, first described 300 years ago. If you've got a tight band and it's causing a contracture, guess what you do? You cut it. Very easy. And that's a fasciotomy. Percutaneous needle fasciotomy has been popularised by the French, and particularly by Dr. Lermuseau at a clinic in Paris, where they've done thousands of these. And I think he's actually a rheumatologist, he's not a surgeon. And this just simply uses local anaesthetic and a needle to divide through the Dupuytren's bands and then gradually break them and extend the finger. It's actually very low cost, it's low technology, it's simple to do, you can train to do it very easily. What are the dangers? Well, you may not correct the contracture, you may cause a hematoma, you may divide a nerve, you may divide a blood vessel, you may divide a tendon, pretty unlikely. But it's a simple and effective way of dealing with this condition, and the skill set that you need for it isn't very high. So it's an option for some people in some conditions, and it's very good for, you know, a very well-defined palmar band with an MCP joint contracture. The alternative, some surgeons turn their nose up at it because they don't want the risk of damaging palmar digital nerves. That's the main problem. And certainly one very eminent hand surgeon who I know thinks it's entirely wrong and said, well, you know, if I want to divide the band, I want to see it, and that way at least I know I'm not causing damage to any associated structures. And he would always go for an open fasciectomy, a little incision in the palm, either divide the band or take out a section of it. And that releases the contracture and you can bring your finger straight. For more severe disease, there's fasciectomy, removing the whole of the Dupuytren's fascia, as much as you can see, but you can't actually see all of it, because if it's genetically pre-programmed to grow, then it's going to come back, and the recurrence rates actually after surgery are pretty high. Or if it's very severe and if it's involving the skin, then the fascial band with the overlying skin can all be removed and the whole thing grafted with a full thickness graft. But you know, obviously the skill set to perform this is actually quite different to the skill set to perform that. Well, there are advantages to surgery. We like doing it. It's a skillful operation. It gives us a buzz at the end of it. You've not cut the digital nerves or arteries and you've got a vascularised finger. Great. What are the disadvantages? And sometimes it helps patients. What are the disadvantages? Well, you know, actually there are many. It requires an anaesthetic. It can be done under local anaesthetic, and there are some centres actually that specialise in doing this under local anaesthetic, particularly in America. Usually in this country, though, we use regional or a general anaesthetic, which is much more common. It requires a fair degree of surgical skill and training, and there is a certain degree of risk in terms that the wound, palmar wound and finger wounds can be quite long. There's a risk of infection. There's a risk, certainly a risk of nerve injury, which in the literature is probably around 7%. Yeah, slightly less than 1 in 10. That's either a neuropraxia of one of the digital nerves or actually division, which is far more serious. There are problems, you know, with the scar healing and with scar sensitivity afterwards. Certainly there's a degree of hand swelling and finger stiffness. And after an extensive fasciectomy from the palm into several fingers, there's actually a fairly long period of recovery in terms of, you know, hand therapy, splintage, night splintage. Well, core of the talk, what about, excuse me, what about Xiapex? Well, Xiapex is an enzyme, and it is currently marketed in this country by the pharmaceutical company Pfizer, but that's going to change because the American makers of the drug, I think, are ending their collaboration with Pfizer, and it will probably go to another company, but we don't know who at the moment. And I think that collaboration is due to end in a month or two. What Pfizer have actually done is they've really developed the idea of using it, marketed it very well and trained people very well in using it, and produced some pretty good results before the drug came to market. It's not the first collagenase that has ever been invented. It's an enzyme. But it's probably the most tailored, if you come to understand my meaning. What it is an enzyme. It contains two types of collagenase, which are isolated from the bug Clostridium histolyticum. And the enzyme cleaves peptide bonds chains when it's actually injected into the Dupuytren's cords. It's a very selective action, and these two types of collagenases act on type 1 and type 2 collagen, which you find in Dupuytren's tissue, also ligaments and tendons. Hence, not a good idea to inject it into a tendon, because just as it dissolves your Dupuytren's tissue, it can dissolve your tendon, which is actually a total catastrophe. However, there are ways that you can be trained to try to avoid that. And the published studies show that the risks are actually quite low if you follow what it says on the box. Nerves, arteries and veins contain another type of collagen, and so they're not dissolved by this enzyme. For the use of it, you have to be trained. You cannot as a doctor or as a surgeon or as a surgeon that's registered on the specialist register, just go out, order it and use it. You have to go through a process of training, which is actually an online training program where you understand what the material is, how to administer it, what the risks are, what you should be advising patients. It's pretty thorough, and it's one of those training programs where you cannot pass go until you have got the right answer. It may take you 57 times to get the right answer, but you have to get the right answer before you can go to the next stage. It has a number of certificated users. They provide very good patient information material, both online and in paper form, and certainly in my experience they have got a robust system for the collection of data regarding any adverse event. So it's pretty impressive. They know that they want to know what happens if things don't go well. And it's also recognised treatment now by private healthcare insurers. I believe from speaking to one of the representatives of the company that even though they would like to roll it out in the NHS, this hasn't always been possible because of drug costs. But what they don't see, is, of course, in the NHS is how much it saves in surgical costs. But that's from another pocket and another budget, NHS managers. So, with Xiapex treatment, there are two visits. The first visit is to administer the injection to the patient's hand. Unfortunately, and this is a big problem for me, you can't administer local anaesthetic with this. It's not recommended. It's actually quite an uncomfortable, painful injection to give patients, and I'm totally upfront with them about it. It's brief. It just lasts, 15 seconds, if that, but it's actually pretty unpleasant. They don't like it, so you might as well tell them. Grit their teeth. The recommended zones for injection are into the palm of the hand at the base of the MCP joint or just distal to that. So there are safe zones that are recognised. And these involve injecting a small volume of the material just below the skin, 2 to 3 millimetres, actually into the Dupuytren's cord. It's very important that you don't go deeper because you will spear the tendon, you will inject collagenase into the tendon, and it will rupture. Bad. And you do it in a 3-point distribution, approximately distally and to the side. It's done as an outpatient procedure, obviously with the patient awake, and afterwards you apply a pretty bulky dressing. When you do that, people wonder, what on earth is that for? Because it's a tiny injection. It's what happens next, during the next 24 hours, that's important, because they do get a fair amount of swelling and bruising. Now, because of the very small risk of an allergic reaction and the very, 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 very small risk of anaphylaxis, you have to keep the patient under observation within the confines of your clinic for half an hour. Very important. I've mentioned it's sore to give. they get pretty impressive bruising and edema. It is very, very, it's a swollen hand when they come back the next day. Very occasionally they complain of systemic symptoms, feeling a bit peaky, a bit off colour, you know, not quite up to having supper that night. There's a risk, as I mentioned, of nerve injury if you spear a nerve, tendon rupture if you inject into the tendon, allergy and anaphylaxis are put in brackets because they are pretty rare. And you can't do it in some people, so if anybody's got a hemorrhagic tendency, if they're on anticoagulants or have a coagulopathy, you can't do it. It's ill-advised in with patients taking tetracyclines, and it's ill-advised in any woman who is pregnant. Though I don't think I've ever seen a pregnant woman with Dupuytren's disease, come to think of it. Now, isn't that peculiar? So the first visit, they have the injection. 24 hours later, they have the manipulation of the finger. Now, this is done under local anaesthetic. Because the hand is actually quite swollen and sore, sometimes local anaesthetic is uncomfortable when it's injected. Sometimes people actually are very apprehensive about having the manipulation, and on one or two occasions have actually done it under as a day case under a light general anaesthetic or heavy sedation. And patients have actually requested that. There's a controlled manipulation of the finger, so you straighten the finger out, and as you do so, there's an extremely satisfying pop as the band snaps. And you feel great. And then there's a little bit more bruising and swelling in the palm as the vessels bleed under the skin. I always warn the patient that the skin may tear. Yeah? If it does, it's no big deal because it will heal, but it will take several weeks to do so. But because the band is often adherent to the overlying skin, it may tear. So warn them ahead of time. And you can have up to 3 attempts at manipulation. Occasionally it's unsuccessful, and it can be repeated into the same band up to 3 occasions at 1 month intervals. So, post-manipulation, again they have a bulky dressing. They get pretty swollen and bruised, as you can see on these pictures. They need some analgesia and they need advice on wound care and redressing if there is a skin split. And they're shown some finger flexion extension exercises, and it's advised that they should be splintered at night. I don't personally put them into a splint during the day, but for at least a month, 6 weeks at night, they should have a splint to try to maintain any correction. What are the results? 2 big studies, Badalamenti, Journal of Hand Surgery, 2007, pretty good, 87% within 5 degrees of normal, and another big study by Gilpin, Journal of Hand Surgery, a couple of years ago, 3 years ago, 2010, 64% within 5 degrees of normal, 74% within 15 degrees of normal. So for a simple treatment, which is actually in terms of skill sets pretty low technology, you're getting quite reasonable results. Overall, what can you advise? Well, if somebody has a mild contracture, they tend to have a better correction than the more severe contractures. That seems reasonable. Metacarpophalangeal joint contractures respond better to this treatment than proximal interphalangeal joint contractures overall. And this is interesting, previous surgery does not seem to affect outcome. Now this is actually, as a surgeon, this is quite good, because revision surgery for Dupuytren's disease is very hazardous. You know, the risks of not achieving good correction, also the risks of nerve or vessel injury, are much higher than the first time round because of scarring around the vessels. So if you can avoid that, if you can lower the risk of that and still have a good outcome, then that seems to me to be very efficacious. What about the complication rate? In my experience, pretty much everybody gets bruising, swelling and local pain. I've had one patient who actually had no response whatsoever to the injection. There was no bruising, there was no swelling, there was no pain. It was as if we hadn't done anything, but we had. And he came back the following day and of course the manipulation failed. Reported it to Pfizer. They said, well, they'd heard of it once or twice before. But it was actually a pretty rare complication, or consequence, not really even a complication, because you haven't made them worse. There were no tendon ruptures in Gilpin's study in 374 patients, and Pfizer in their literature published data of 3 tendon ruptures in over 1,000 cases. So, you know, the risk of tendon rupture, I advise people, is less than 1%. The recurrence rate, well, in this country it was started to be marketed in about spring of 2011. So it's been on the market in the UK for about 2 years. It was a little bit before that in the US, and there were some previous studies which were administered by the drug company for a few years before that. So really overall published recurrence rates over time don't seem to really now be much more than 4 or 5 years anyway, out from inception of these studies. But overall there's very limited published data. It seems to be a 14 recurrence rate at 2 years, which I would find quite acceptable for this type of treatment. So in summary, it seems to offer a safe, effective, non-surgical treatment for Dupuytren's disease. Needs more studies regarding long-term recurrence rates. There are risks and they need to be explained to the patients. But overall, the risk-benefit ratio for this type of treatment does seem to be very advantageous in comparison to surgery. Thank you.